Welcome back. During the first part of the program, we heard about the work at MAO, and now let's talk about the project in North Alabama. Mary Elizabeth, will you share with us some of the telemedicine experience from an administrative perspective?
Absolutely. Thank you, Rainey. And I want to echo Dr. Batt in thanking ADPH and the Southern AIDS Coalition for helping to let us publicize this on a national level. I don't know if there's anybody out there in TV land, but if so, we'll hear from people in a short while. So back in 2009, Mike and I were looking to write a grant to AIDS United for access to care, to try to bring our state a little bit more together. And so we looked at telemedicine as something that was being done, especially in the Black Belt with psychiatry. And we thought, well, why couldn't we link our clinics together and to try to build access out in our rural communities? So if you can visually, I don't have a state map up here, but if you can visually think about AIDS Action Coalition's service area, we are the top quarter of the state or so. We go from Mississippi to Georgia and Tennessee all the way down to Birmingham, all the way through Coleman to Birmingham. We have a site in Huntsville, and then our second site is over in Florence, which is approximately an hour and a half away. Mostly 2 4-lane roads to get there. And I was looking at, number one, our clients didn't have great access out in our Florence clinic, where we would go twice a month. We had a social worker out in that clinic 5 days a week, but as far as medical care, we could only be out there twice a month. And so I was looking at access to care and also that almighty uncompensated time that we spent with, again, as Dr. Bott talked about, sending out a phlebotomist, sending out a nurse, sending out a provider. And that's a lot of people to put on the road for an hour and a half one way when they're not seeing patients. So telemedicine seemed to be a really good idea to get that to happen, or to increase care. Not only were we not seeing patients during our travel time, but one of the other things is that we have our no-shows. And when you have a full day scheduled out there, but maybe a half of the clients don't show up, which of course we don't want to happen, but things do happen. Then you have a whole group of providers that are sitting out in Florence with nothing to do, and again, that's very, very much uncompensated time. If that provider is sitting in Huntsville, they can see patients even if we have no-show patients in Florence. So that's really maximizing what we need to do for our clinicians. The expensive transportation costs were also daunting to think about. The fact that we do have a van, but you've got the cost of upkeep of the van, you've got the gasoline, you've got, and again, that uncompensated time. So we would have clients that may travel anywhere from 1 to 4 hours for a lab result appointment, which, we don't do those kind of appointments over the phone because other things may come up in that appointment. But if you did have a client that just came for a lab result, that seems like a very big waste of time to travel 4 hours just for that appointment. We have an agency driver for clients who have trouble with their transportation, but if you can think about going from Huntsville all the way over to the Mississippi border, that may be 2 hours, 2+ hours, to pick a patient up, bring them all the way back to Huntsville. They sit for their appointment, then they go all the way back to Marion County or Red Bay, and then come all the way back to Huntsville. That driver is spending an 8 to 10 hour day to provide transportation for a small number of patients. Of course, in the HIV/AIDS world, we're going to do whatever we need to do to get people into care, but there needed to be a better way of doing business. So now with Florence being halfway between, at least we're reducing that time. And I'll talk a little bit about the additional services that we've got planned in the next couple of months that'll also take care of some of these transportation costs. So the increased access to care, the clients in the Florence satellite clinic, we went from 2 days a week to 2 days. I mean, we've gone from 2 days per week and versus the 2 days per month that we were doing, and those decreased travel costs. We're also seeing, I think it's just coming out of now having more access to care in Florence. In a 2-week period, I've been on the road a lot, but I think it was about 3 weeks ago I was out in Florence, and our social worker told me that she had seen 6 new or reestablished patients during a 2-week period in Florence. This is a tremendous increase. I think this is partially because clients are now realizing that they don't have to travel maybe all the way to Birmingham for their care or to up to Vanderbilt. That they can be seen for their HIV care right there in Florence, and so as the word gets out, I think we will see a tremendous increase in the number of clients that are being seen. So this works to linkage to care, which is what we are all trying to do in this country, is to try to identify people that are needing care, getting them into care with linkage to care, and then retaining them in care through having established partnerships in clinics and such. So some of our new services that we're providing in Florence is that we have begun using access to our psychiatrist, who is in Huntsville, to see our patients in Florence. And when I see, I'm talking about the virtual seeing patients through telemedicine. Dr. Archibald is very open to using telemedicine, and he sees it as again, that travel time between Huntsville and Florence, but being able to see more patients for our buck, kind of, so to speak. We are now also expanding our telemedicine equipment in Huntsville, between Huntsville and Florence, because we have secured a SAMHSA grant where we have been providing telemedicine IOP in Huntsville. We are now going to start an IOP in Florence. We are going to connect those IOPs with Polycom telemedicine equipment. And what that will do is that it will enhance the experience for the clients in Florence to be able to be part of a bigger group in Huntsville. What we would like to see is that the counselor would be the direct facilitator in Florence 1 day a week, and then in Huntsville 3 days a week, having a facilitator sit in on the group in Florence when they are not facilitating. This will again be able to enhance the experience and also expand what we're able to do in Florence. So besides outpatient ambulatory medical, we're doing case management, we're doing the psychiatry, we're expanding to our substance abuse and mental health, and also our translation services. So I think I told you that I had the smaller part of the presentation. I've tried to stretch you guys and talk slowly, but I think that, before we wait and see if we've got questions, I wanted to piggyback on something that Sandra had talked about with the stigma. We were talking at a statewide meeting yesterday. This isn't something that happened 5 years ago. This was something that just happened this spring, where one of our sister organizations, after an advocacy day down in Montgomery, where we were all wearing red T-shirts, they stopped at I'm not going to call out the name of the store, but they stopped at a store on 65 on the way home, and somebody asked them what their red T-shirts were all about because it said "Stop AIDS" on the back of the T-shirt. And when the proprietor of the store, he heard about it, he asked them to leave because he didn't want AIDS in his store, which is just bizarre. This is not 1988. This is 2014, 13. So stigma lives in Alabama.
And Mimar, I'm interested to know, you've heard me, I'm not from here originally, I'm from India, so I'm a transplant to Alabama. Why is the stigma present? What do you think? What are your thoughts about what is the basis of the stigma? Why are people so afraid of HIV?
Well, I think that it's because they don't perceive it to be something that is... I've got a summer cold that will not go away. I think that they perceive it as being a large city problem and not a rural problem. And so I think that's part of it.
I think the other part of that is just a lack of education. Quite simply, it's a lack of education. And if we can get to those rural areas and try to help educate people about HIV and AIDS, it is not the end of the world. All it takes is a pill, and you can reduce your transmission rate. So I think that if we could get to people and let them know that it's not something stigmatized that only affects one type of person. It's something that's increasing in rural areas, in the Deep South, in the Bible Belt. It's a real thing, and it's something that needs to be addressed and not completely ignored and shoved under the rug.
And I feel when you say lack of education, I believe that lack of education is not going to go away with just some scholarships. It's a lack of education of the sense of community, the lack of education in the resources, it's a lack of education of the disease process itself, or the lack of education which actually makes some people to behave differently towards certain sets of people.
Well, it's not only lack of education in all those areas that you talked about, Dr. Bott, but it's even lack of education of our providers, which I think we all see here in the Deep South and in Alabama specifically. And hopefully with telemedicine, we're also going to be able to, begin to educate our providers out in the community and out in the rural areas so that when they see something that they're not equipped to handle, that they can call either, they can go into either Huntsville or Tuscaloosa or Montgomery and help with some of that specialty care.
Absolutely, Mimar. And I am actually proud to say that we as MAO have been instrumental in training medical students and residents, like I said before. And it's kind of a sense of accomplishment when I see that when some of the young doctors or medical students come in first, and I'm seeing them through the telemedicine on the other side, and they're wearing gloves to touch my patients, and at the end of that 30 minutes or 20 minutes, whatever, they're so friendly with the patient, they give a hug to the patient then. So that I do believe that there is that lack of education among healthcare people exists.
I think so too. I think so too.
I think that's a really good point, that once you have telemedicine in place and once that technology has paid for itself, you can use it for so many other things, whether it's training for social workers or providers or just a number of different continuing educational opportunities.
Absolutely.
So that's a really great resource. That's kind of just icing, that just sweetens the deal, as you said earlier, to having a telemedicine program.
We've even used our telemedicine equipment for board meetings. So because again, we've got board members that live in Florence, and through using telemedicine equipment, also when we have full staff meetings, so our staff that is in Florence, they don't have to travel to Huntsville, they can go ahead and stay in their community and still participate in our full staff meetings. So it just opens up so many things that you can do, increasing your capabilities of providing overall care for your clients.
Absolutely, yes. the Alabama eHealth Initiative, which comprises of 47 counties of 67, which includes Mimar's, Huntsville, as well as Deborah Tucker's Tuscaloosa, along with our Montgomery, Dothan, the medical aids outreach area. I have to say that we do get a non-conventional burden of HIV in that more than 50%, I've been told, of new infections happen in our catchment area. And if we could get our people with HIV into care, and if we were to get our people undetectable, the risk of transmission goes down. This is a huge public health benefit. The HPTN 052 study actually said that the risk of transmission, the transmissibility of the virus, goes down 96% in a person who is chronically undetectable. So when we get the patients in care, not only we are improving the patient's health care, but we're also improving the health of the community and preventing new infections.
Right, and that goes back to some of it's life-saving care, and then on top of that, some of the cost-effectiveness data that you alluded to earlier. The official data hasn't been released, but anecdotally, we can say that if 0.24% of new infections are averted, then this technology is cost-effective. So it's a really amazing thing. Before we open up to questions from our live audience and to our online viewers, would you want to add anything else to the discussion as our panelist?
The only thing I'd like to add is that I think that another part, anecdotally, of what this has done is that it has brought our organizations much closer together. We realize that many of our barriers and challenges are the same, whether you're in Montgomery or you're up in Huntsville, and just the collaboration between our two organizations has been delightful.
Certainly. There's definitely strength in numbers and in communication and collaboration, for sure.
Absolutely, absolutely.
So thank all of you so much for your presentations. And now that includes the presentation portion of our webcast, we'd like to open it up for questions from the audience and from our online viewers. So please call in or email your questions.
Oh, go ahead.
I do have a question. I'm curious, and I guess it's directed a lot to Mary Elizabeth and to Dr. Batt. The positives are very good. I'd also be interested to know what challenges you all found, because for people out there thinking about it, I know they're in the back of their mind, they're saying, okay, that sounds so nice, but what if? So if y'all don't mind, maybe share a little bit about some of the challenges you found, both as an administrator and also as a provider.
As a provider, I can say that the challenges would be to implement the resource, Mike. Like I said before, the biggest challenge that we faced was actually the areas without internet connection. And I believe thanks to cable TV, we are seeing less and less of those areas, but it is the truth. And second barrier, I think, is probably the lack of education among providers, be it providers or the nurses actually. Some people might think that the barrier could be the patient's comfort level. In my experience, it's not become actually. I was talking to Dr. Thomas earlier about how patients receive this as a technology. It's been very positive because our patients in West Alabama, where there is great food and pine trees, nothing else, and good people, are grateful and thankful to us. And we are thankful to them also. So it's a win-win situation, I think. So if the patient or a person who is getting the care is apprehensive about the technology, the number one apprehension would be, would it be broadcast for everybody else? Would anybody know this one? Because I am on TV. So before the person even gets into the suite, we actually tell them and reinforce the fact that this is 100% confidential and it's HIPAA compliant, and their data will not be seen by anybody, and the encryption that we use is top class.
I think our only barrier has been actually with the providers, not with the clients. Dr. Batt is very, very open to this as a new technology, but a few of our providers have been, they want to touch the patient. They want to have that human touch. So I think that's really been the largest barrier, Mike. Our clients have also been very, very receptive to it. And everybody's a little bit of a ham on television, I think. And also, you know, with younger people, this is, I mean, videoing is not anything unusual. But it is our providers that want to have that human touch that have seen it more as a barrier.
More.
I would
Roy.
ask Mary Elizabeth, have you as an administrator found any strategies to sort of get them to buy in
No,
to this?
no.
It's just,
I've
that
just
they're
said
used
we're
to
going to
this.
do this. We're just going to do this.
I think people grow
No, I'm
accustomed to
just
the
being
status quo. And
I
sometimes when
think
something's new, it's hard.
When something is new, anytime we have any change, everybody, you know, people are all get uncomfortable with change. But as they see that this is really the wave of the future, this is not all that unusual in other parts of the country.
Right.
I think that they're growing more comfortable with it. And I think the more we do it, the more comfortable we become. Now, I will say, just as any new electronic device, there's also the issues, oh my gosh, connectivity, you know, if we're doing everything quite right. And I remember back when we started using fax machines that I had to ask every time how to use it.
Can I
And
just say
you just
something
push
on
that button.
This is, like I said earlier, it is just like a Skype phone call. You know how you go into Skype and you can build your contact list? It took me 5 minutes, maybe less than that, to learn how to use the equipment because we have this tiny little control panel. It's like a TV remote. And it has a dial pad on it, and a call button, and a hang up button, and a mute button. And you go in there and you can program all of your contacts. So we have at MAO, we've already programmed all of the offices, the hub sites, and the satellite clinics. And all we do is we press the green call button, press the arrow down to the contact we want to call, and press the call button again.
And the contacts that
So-
you're putting in are actually
The IP address.
Yeah,
IP
IP address.
addresses. So it is very easy, but again, when technology is new,
Now,
there's that little bit of uncomfortableness.
I'm really curious about that, Mimor, because I've known your providers and they're very receptive people. So, really, they are.
I hope they're watching.
Teresa, a fantastic
Oh,
nurse practitioner. and Dr.
wonderful,
Lyron.
wonderful providers.
Now, how is the community reacting to that? How are your clients thinking about they have seen the benefits of telemedicine, when they do know that when the access could be vastly higher, how do they react to a small glitch called the provider dissatisfaction?
Well, I think that Teresa is probably not, she's going to kill me when I get back to the office, but I think she does not probably voice her wish that she could touch the patient. I think she probably handles it very well with the client. I think the benefits very much overweigh the challenges for sure.
Which brings my next question actually to the panelists. How has your community, I can speak about Montgomery, how has North Alabama community walked the line with you in this endeavor?
Well, I think what we hear is, oh, you're doing that here? Gosh, I didn't know that we were doing that here in Alabama. Those are the kinds of things that we hear. They're surprised that we've taken on this technology.
Fantastic, and I can vouch for Montgomery, and Sandy can resonate what I say, that the Central Alabama community, South Central Alabama community has been a huge, huge support and of assistance and of direction for us. In fact, when we got the grant, it was walking on the edge of sword, actually, that thin thing there, because we did get the money, but we had to match it. And it was a lot of money. And elsewhere in the country, people could match it in 1, 2, 3 months. And we were kind of going slowly with that one because of our geographical location or economic status or whatnot. But I am really proud to say that the South Central Alabama people, the community, actually got this one for us. We raised every single dollar that was needed to match the grant right on time because of the help of our people. And I'm extremely thankful to that one. And I also have to say that community in Montgomery, in general, especially Junior League, has been with us for the past year. So they are our food bank collaborators and the volunteers of Junior League. This is all voluntary work. They are not getting paid for this one. They come and assist in preparing the boxes or giving the foods to the patients. And Miss Ashley in the audience is actually a Junior League member.
That is very important for us to point out. This was a one-for-one match, and it was difficult. It wasn't the $50,000 that we had to match. It was actually $500,000 a year that had to be matched. And when we talked to our cohorts around the country, they could make those matches in the large metropolitan northern cities with 2 or 3 grants. And when they got our when they got our invoices, pages and pages and pages of $10 donations, they were very, very surprised at the amount of work that went into making up that total match. But I think it's been worth it.
Absolutely, yes, Mimar. Have you had any local collaborators? Because I have to say that the success of our telemedicine would not be present without our strategic partner, Selma Air. I have to say, Selma aids information and
Referral, I think.
Referral, yes. They've been very instrumental in providing transportation to our patients in West Alabama. They bring the patients to the telemedicine suite because what's the use of telemedicine if the patients not show up, right? So they provide housing and transportation and medication assistance and such.
Well, some of our, I'm taking this off the top of my head, but thinking about our financial collaborators, Compass Bank, several other banks were instrumental in Alabama. We also had the help of Huntsville Hospital Foundation. So they were people that really saw the benefit of what we were trying to do with telemedicine, and that's how we got those collaborations going.
And my quick question to Rainey, I know you are emceeing this panel, but Southern AIDS Coalition, what is Southern AIDS Coalition's interest in telemedicine?
Our interest is to share this information with stakeholders around the South. So we're a regional organization of 16 states in DC, and we've had the directors that are part of our organization in South Carolina and in North Carolina and other states ask about this program and want to come and see this program because they feel they need that in their state, and the epidemic is very similar in their state. And this is a way for us to bring the information to them. And we think that it's important and it's vital, and this is something that people need to hear about.
Thank you very much.
Do we have any other questions from the audience?
Audience questions? No, we have several emails that have come in if you want to go
Okay.
ahead and get to those.
Do you want to just read the question from the emails? Okay.
Yeah. The first question is asking if you do telecounseling for clients in rural areas. It seems the hardware needs would be less than for telemedicine, and what kind of hardware would you need if you utilize that service?
So if you only did the counseling and maybe not the medicine
Then you would
part?
not need the peripherals. You would not need the scopes, the ENT scope, the derm scope, and the stethoscope. You would just need, and this is what we're going to be using for our substance abuse and mental health IOP. It would just be the video screen and a microphone. And yes, we do utilize that.
We as well.
Okay. There's a couple questions here regarding reimbursement from insurance
we didn't talk
companies.
about that.
That's
I will
great.
stay away from reimbursements.
I can talk a little bit about reimbursement.
Yeah, we can talk a little bit about that. Medicaid reimburses the same as an in-person visit at this point. It's been coded to where it reimburses for telemedicine. Private insurance has been a little more slow to follow, and the hope is that Blue Cross Blue Shield and other private insurers will also follow and will have the same reimbursement rate as Medicaid.
And that was a concern for us because without that reimbursement rate, then you're not being able to be self-sustaining
Right.
once the equipment is paid for and to sustain and help with the cost of the provider. But as you said, Medicaid in Alabama has approved it, and we're hoping that everyone else is going to follow.
So that's going to be a state-by-state thing that you would encounter. It may be different in other states. Some states, their Medicaid program may have but they might not have any written codes about it. So once that state had a telemedicine program, they would have to go back and write the code. But in Alabama, it was originally just dermatology, maybe through telemedicine, and something